All right. Good afternoon, everyone. Welcome. Welcome to our fourth CCDS Patient and Scientific Symposium. I love the name of the symposium. I remember debating on this name, and we said, we're putting the patient in this event. And I feel like we have every single year. And honestly, without these kiddos that come and sit at the tables with the researchers, we wouldn't have half the impact we do. So I'll just, every time I come up here, get ready, because I'm going to gush about all of you loading up and traveling across the country and across the world, coming here, putting your lives on hold, and making sure that you are representing your family and your child and your unique experience, because without you, we'd just be talking about Sam and Louie. So thank you for being here. We are going to get started, and hopefully everybody got a welcome bag. If you don't have a badge, that's okay. We're getting them all in order, and you can pick those up later in the afternoon. We did badges for a lot of the kids, and they don't have to wear them. We wanted them to feel included, but also, if they hate it, take it off and throw it away. We don't care. Let's see if I can move these slides forward. Okay. All of the events for the adults take place in this building. So every meal is served at the back of the room. The gala will be here. So really easy to kind of orient yourselves. Our kids are just on the other side over here, coming and going tomorrow and Saturday. Today, they're all just here. Nobody's at the National Ability Center. And when we wrap up, we'll go grab the kids, and then we'll be back in here for dinner tonight. You should have a schedule in your bag. And don't forget, you can also download an app for your phone. And with that, thank you. With that, I will get my slides lined up with my talk. So today, this special session, this is a little bit longer symposium, so thanks everybody who made it today to extend your weekend. We are concluding a long project we've been working on for about 4 years now, and we're really grateful that you're here, because this is probably the most important meeting for you to stand up, ask questions, tell us how you really feel. Don't hold back, because that's the purpose of this whole project. Just so you know, today's Alignment Jam meeting is being recorded. Portions of it will be shared publicly online. The discussion sections will not be posted online. So when we open it up and you're wanting to share something very personal, we're going to edit that part out. We may also use de-identified quotes. So if you say something really awesome that we think, man, that has a lot of impact, we may quote you, and we won't say who it was and where you live and your child's name. And I think that pretty well covers it. So the PARENTS stands for Patients Advancing Research Networks. That's our big, long, funny spelled PARENTS, what that stands for. And in this second project, 2.0, we are especially focused on expanding our community. We had a couple dozen folks that were involved in PARENTS 1.0, and we were able to recruit a whole nother group of caregivers who met with us every single month on very long meetings every month, an hour and a half, from around the world, and contributed to what we're going to be sharing this weekend with you. The current Parent 2.0 project was designed as a follow-up to the first project, and in the first project, we had identified the most important outcomes as identified through multiple surveys with multiple folks to be the most important to keep track of and see improvements in clinical trials for when those happen. And that's going to be the highlight of this weekend, is that those are going to happen. And in this second project, we're talking about how to measure those improvements. So 2 years ago, we said we want to see improvements in my child's cognition or their ability to regulate their emotions. And we've dialed in on now, what does that mean for you? So as I said, this has been a long process. This highlights the process, and my husband's calling me over and over. Sorry about that. We are highlighting the process here, and we also will have a poster on Friday evening, and Celeste will be sharing that, and you can come back and kind of dig in on all of the background on how we got to where we are today. But I'm gonna go through that a little bit quickly and say that after all of these meetings with all of these subject matter experts, including and especially parents, that we landed at the alignment jam that we're in today. So on your table, you should see that you have a handout, and this is meant for you to keep. You don't have to turn it in, so don't worry if you want to make a note that feels personal. It's yours to keep, and it's to help you to reflect back when we get to the questions. You can remember what you had a thought about cognitive behaviors and all of these different things. So they're for your eyes only. We will not collect them. Now I'm going to skip forward to one of the outcomes that we decided was of great importance for GAMT patients, which is plasma GAA. That's measuring basically the neurotoxin that's elevated in children with GAMT. And this has been the kind of the cornerstone of treating children with GAMT. And you go in for your regular appointment, they say, oh, looks good, your GAA is down, or, oh no, it doesn't look good, it's up, and we're gonna have to make some changes. And we, as part of this project, assembled subject matter experts to dig in on some of these, because if we say we wanna measure this in clinical trials, how are we measuring it? Are we sure that just pop into the lab anytime you want and get a blood draw is giving us consistent and meaningful levels? Same thing with creatine, honestly. We track that as well. And are we keeping the creatine levels high enough? And we had both subject matter experts, Dr. Schulze, Dr. Pasquale, who met with us many times, and parents who met with us many times. Tony Tedesco from Australia, many of you know, he's a clinician and a GAMT parent, and Carrion from South Africa. And they had done some independent studies where they had recorded their children's GAA. And many parents had the same intuition. I don't think that this can just be measured in any time, before or after meals, after supplements. And we think there's more to this. So Dr. Schulze is not able to be here. He'll be here this weekend, but he wasn't able to make it today. And so I'm going to share some of his slides with you on the project that we created as part of Parents 2.0 to look into how to measure plasma GAA. To do this, it was proposed that it's very difficult to tell our kids, we're going to do a blood draw. Like, all of our children do not like that. Very painful, very uncomfortable, very expensive. I know for myself here in the US, it costs me about $600 every time I have this test done. And so we looked to another way of getting this measurement, which is the DBS, dried blood spot. This is the thing that our children have done when we do newborn screening and their heel is pricked and they collect the drop of blood. Well, with other metabolic disorders such as PKU, the children are monitored in this way, and they track their phenylalanine to see that it is well controlled, and they do it at home with a little piece of paper, a little lancet. It's very convenient, and in fact, in most states here in the US, the testing is covered by the government. How wonderful would that be? And also, how much more frequently would we be monitoring our children? But the question is, would this be something that is appropriate? And will we learn whether or not these levels of GAA are stable or changing throughout the day based on many different variables? So, is the concentration of GAA dependent upon the time of collection? We anecdotally know that some parents have had an early morning, say my child just had a seizure, they went to the ER, give them a blood draw, and their levels are very different than what they thought they were operating under. So we've got some suspicions there. Guanidino acetate levels in guanidino acetate methyltransferase deficiency patients, circadian study. This is the study that's proposed to answer these questions. And the objectives are to evaluate the levels throughout the day. Are they changing? Are they fluctuating? Evaluate the levels before and after taking medications and supplements. So if you take your creatine, ornithine, sodium benzoate, and you test again an hour later, is there going to be a big change? And then evaluating GAA levels before and after meals. So how about the effect of food? And how will we do this? We partnered with Dr. Schulze. He has a REB approved protocol and a study that we have helped fund the materials for, and he's enrolled patients. And in fact, we have room for a couple of more patients, which I'll mention at the end. But these patients are consented and explain the risks and benefits, and they're sent materials, and they're collecting these blood spots on cards at home. And they are keeping track of all of these different variables. So they are taking samples throughout the day, on 2 days, and then again on a separate week. So we have many samples taken, and the kids still hate it. But they're troopers, and there's been a lot of bribing happening, and we're all working on it. So the study is underway. We are not done. GAA levels in guanidino acetate patients. Again, families will be asked to sign the consent, document all of the times of these different factors, when you ate, when you gave your medications, and then the tests will be performed in Dr. Schulze's lab, and he will measure the GAA and the creatine and the arginine and the ornithine. So we'll see how all of these levels change. One hot topic with GAMP patients is that ornithine level, and it's been said that decreases very quickly and needs to be given more throughout the day. Well, we're going to prove that that's true or not, and try to optimize dosing as well. So the update is there are several enrolled. Some have turned in their materials, some have not. And while it says that there are 10 enrolled now, update in June, there is room for more, because there will be some of our kiddos that are not able to tolerate this whole process. So if you're interested, please reach out to me. This is a quick snapshot, though, of 2 of the patients who completed it. And while overall, it looks like, this is a pretty smooth reading, that this patient on the top is at about 6 GAA. You can see, like, what a huge variation this is if you are taking your child in and having GAA levels measured to inform your child's care. You may go at one time of day and be told, fantastic job, you're at a 4.5, and you feel great. And really in the very same day, that same patient had a 6.2 or so. And if you had done the blood draw at that time, you may feel a little down, and I'm doing something wrong, and I'm just not doing a good enough job. And it's very, very difficult. So I think this is an awesome study to highlight your clinician needs to be tracking all of this together with you to determine, have you really made improvements or not with the current treatment, and do we need to make adjustments? So I added this slide to kind of call some of this out. That there are benefits to a clinical trial for GAMPs in this study, that we will learn about these natural variations and how to control for those in taking measurements and saying, does this drug work or not? Also, there's potential benefits to the patients. We could now, at the end of this study, advocate for those same labs who are testing for the PKU patients. Why don't you test for GAMP? Why don't you help us keep better check and better keep our eyes on this moving target a little better, and see how we're doing and make quicker adjustments? Maybe our child is growing, they're going through puberty, and we didn't know because we were only asked to do this very expensive test every 6 months, and we go in and surprise, your GAA is horrible, and we should have cranked up your creatine 20 pounds before your child got to this point. So this would help us really stay on top of the current available treatment. And even without monitoring from home with dried blood spots, we could just plan our blood draws better, and our clinicians could tell us, this is what you got to write down, this is the time I need you to go in after meals, and we could take better care of our kids. So again, the same things, benefits to our clinicians, they can help us to help our kids better. So the study is still recruiting. Please reach out if you are interested. And with that, I am going to turn it over to a presentation from Jamie Capal from Cincinnati Children's Hospital. She was our subject matter expert group on seizures leader, and she really delivered some very helpful guidance around epilepsy, recording epilepsy. So how would seizures be tracked in a clinical trial, and how can that help to be successful in this outcome measurement? So with that, I will let our AV folks take over.
Hi, everybody. My name is Jamie Capal. I am a child neurologist at Cincinnati Children's Hospital Medical Center, and I'm here today to talk to you a little bit about how to identify and document seizures. So just to give you a little bit of information on what is a seizure. So a seizure is considered a sudden, temporary episode of abnormal electrical activity in the brain. And this disrupts normal brain function, so it can affect your awareness and your consciousness. It can impact movements, how you input senses, and can affect emotions. Seizures can last several seconds to several minutes, and most seizures last under 5 minutes, but there are instances where seizures can last longer. Seizures can happen any time of the day or night, and sometimes there is no trigger or notification that these are going to happen. But we do know there are certain triggers that can increase the risk for seizures. So if somebody is sleep deprived, if they're on an anti-seizure medication and they miss their medication or take it late, sometimes big emotional stress can precipitate a seizure. Illness, fevers, in certain circumstances, flashing lights can induce seizures. And then in females, sometimes menstrual cycle and those hormone changes can influence seizure activity. I'd like to take a few minutes to show you a video on managing seizures in children.
Each year, more than 350,000 children from birth to young adulthood suffer some type of seizure. Many of these are treated and cared for at Children's of Alabama. This video will teach you about different types of seizures and what to do if your child has a seizure. You will learn about the following: febrile seizures, infantile spasms, focal seizures, drop or atonic seizures, myoclonic seizures, absence seizures, formerly called petit mal, and generalized tonic-clonic seizures, previously known as grand mal. A febrile seizure is a seizure caused by a fever and is not considered to be epilepsy. Up to 5% of otherwise healthy children between the ages of 9 months and up to 6 years will have a seizure caused by a fever. Most febrile seizures occur within the first 24 hours of an illness. Common signs of febrile seizures often begin with a sudden cry, stiffness, followed by jerking of the body, and usually last only a couple of minutes. In this example, notice how both arms of the 1-year-old boy are raised and stiff. His eyes and head are jerking. His whole body is involved. Even though his mother is talking to him, he is unresponsive and unaware of what is going on. Infantile spasms. During infantile spasms, the infant has quick and repetitive movements, which can be numerous. This 3-month-old boy is having a cluster of spasms indicated by the extension of his arms. You have to watch closely to notice the seizures, which is why infantile spasms are not easily seen. Infantile spasms occur between 2 months and 2 years of age. appear in clusters, often when waking up or falling asleep, and can be mistaken for hiccups, colic, or a bad stomach ache. Here's what to do should your child have an infantile spasm. Note how many spasms occur. Call your child's doctor immediately if you think your child is having a spasm. Focal seizures are also called partial seizures because only a portion of the brain is affected when the seizure begins. Common signs of a focal seizure include a blank stare, altered awareness or seemingly being out of sorts, repetitive behavior such as chewing or picking at clothing and mumbling. In this example, the boy's eyes are open, but he is unaware of his surroundings. He is unable to follow simple commands. Focal seizures can last a few minutes. There may be a time of confusion afterwards that can last much longer. Many children are sleepy and may not remember the event. What you should do: speak calmly and remain with your child until the seizure is over or help arrives. Do not try to hold your child during the seizure. Call 911 if symptoms persist. Sometimes these seizures may progress to a more serious type of seizure, which we will discuss later. Drop seizures or atonic seizures cause a sudden loss of muscle tone. Here are common signs of atonic seizures. The child stumbles or falls, which can cause injury. The seizure may be mistaken for clumsiness or poor coordination, since the child will usually recover within minutes and be able to stand and walk again. Watch this 3-year-old boy as he stumbles and falls back in this sequence of seizures. Here, the child's head drops and he falls backward. He continues to have seizures while sitting in his mother's lap. Notice as his head drops forward, similar to that of catching oneself before a fall. Call your doctor immediately if your child has these symptoms. Some children who have atonic seizures will need to wear headgear for protection from injury. Myoclonic seizures cause a sudden jerk and usually happen in the morning. In this example, the child is having sudden jerks of his upper body as he sits at the breakfast table. Call your doctor immediately for help. Absence seizures. Watch this 7-year-old as she does her homework. While writing out her assignments, her hand suddenly stops. She looks up and briefly stares into the distance. Common symptoms of absence seizures include a blank stare that begins and ends abruptly, lasting only a few seconds, rapid blinking and chewing, unawareness of what is going on during the seizure with a quick return to full awareness after the event. Can occur a few or up to hundreds of times a day and are often mistaken as daydreaming or poor attention. Here is the same child at a horse show. The excitement and anxiety of the event result in a mild seizure. Notice how she steps forward briefly. She almost comes to a complete stop, then goes on to participate, unaware that she has had a seizure. While children with absence seizures frequently have trouble in school, the majority respond well to treatment with seizure medications. A large part of the brain is involved in generalized tonic-clonic seizures. Tonic means stiff and clonic means jerking. Generalized tonic-clonic seizures are the most dramatic of all seizures. They often begin with a sudden cry, a fall, rigidity or stiffness, and muscle jerks. They usually last only a couple of minutes, and the child may be irritable and sleepy for minutes to hours afterwards. This 4-year-old has lost consciousness and is stiff. Notice that his head is turned to the left and his eyes are fixed to the right. The jerking is intense and his entire body is involved. As the seizure comes to an end, you can see that the jerking is gradually slowing to a stop. Normal breathing returns and the child goes to sleep. Here is the same 4-year-old we saw having the seizure in his bed. Now happily playing, he has no memory of the seizure he had the night before. In summary, a generalized tonic-clonic seizure lasts a couple of minutes and often begins with a sudden cry, stiffening, and jerking. Other symptoms include unresponsiveness, loss of consciousness, possible loss of bladder or bowel control, excessive drooling, shallow breathing, and sleepiness, confusion, or irritability after the seizure. Here's what you should do if your child is having a generalized tonic-clonic seizure. Call 911 if your child stops breathing or turns blue. Place your child on his or her side if possible. Clear the area around the child. To help avoid injury, place something soft between their head and a hard surface. Time the seizure. If it lasts longer than 5 minutes, immediate medical attention may be necessary. Remember to follow these guidelines with any type of seizure. Do not put anything in the child's mouth. Do not try to hold the child's tongue. It cannot be swallowed. Do not try to give the child food or drink. Do not restrain your child. Keep in mind, your child may be susceptible to a seizure if they have a fever, illness, or infection, they are tired, overheated, or under stress, or are excited, anxious, fearful, or sleepy. If your child is prone to having seizures, keep the following in mind. Never allow the child to swim alone. Have the child take showers instead of baths, and avoid heights. If possible, videotape the seizure, as this could be helpful to your child's physician. Call your child's doctor anytime as needed.
Next, we'll talk a little bit more about seizure types and how to identify them, as well as some of the symptoms that you may encounter with those seizure types. So I like to think about seizures in two main buckets: generalized, meaning impacting both sides of the brain, so the whole brain, and focal, which may only impact a small part of the brain. And within those two buckets, you can have motor manifestations and non-motor manifestations. So a few examples of generalized seizures. The ones we think about most often are generalized tonic-clonic seizures, meaning you have full body movement. The individual is unconscious and has a lot of muscle stiffness. Less apparent generalized seizures could be absent seizures. So these what we consider staring. And kind of not responding to their names. Myoclonic, which are really brief jerking movements. Clonic just means a repetitive rhythmic movement, and tonic just means a stiffening of the muscles. And then atonic is what we refer to as a drop seizure, so a complete loss of muscle tone. Within focal seizures or partial seizures, you can have impairment of consciousness or preservation of consciousness. For preservation of consciousness, we often call these simple focal seizures because they're really starting in a very small part of the brain. So, for example, you may have just one arm that's moving rhythmically, or one leg or something like that, but your awareness is completely retained. Also can have kind of some simple sensory where you may smell something or see something, or psychological. So sometimes we hear of children getting really scared or something, and that may often lead to a bigger seizure. Complex means that there is some impairment of awareness. Doesn't have to be complete unconscious, but the individual may be slow to respond or may appear confused. And sometimes those focal seizures can, what we call secondarily generalized, which means it then starts to impact both sides of the brain. So what are some things that might look like seizures? And there are many, and this is just a list of the most common ones. So in babies particularly, Gastrointestinal reflux can look like a seizure because babies will often arch their back and stiffen. But these are usually are surrounding feeds and don't happen at other times. In young children, we see breath holding spells, which can sometimes look like a seizure if they're holding their breath for a long time and may pass out and have some rhythmic movements. Syncope or fainting. Tics and stereotypic movements, depending on the type of movement, can sometimes be mistaken for a seizure. Certain sleep disorders, so in young children who have night terrors, so waking up in the middle of the night, screaming and being kind of not awake and inconsolable. Shuddering attacks, and this also happens in infants. Behavioral staring, so sometimes staring off into space, not really responding to your name, but those sometimes or often are not actually seizures. And then benign sleep myoclonus, so often when people fall asleep, they may have some jerking of their arms or legs, which isn't a seizure, it's just your body relaxing. So what are some tips on how to distinguish a seizure versus something else? So if you are able to, if your child is small enough, I would recommend you pick them up, or you can reposition them to see if that movement or if they're staring, that is to see if your child responds to you or that movement stops if you reposition their arm or their leg. You can also try to suppress the movement. So if an arm is jerking or a leg is jerking, trying to stop it. If it's still jerking under your hand in a rhythmic fashion, then that makes you more worried that it could be a seizure. Often calling someone's name may not get their attention. So I will often say, get in their face, touch their shoulders to see if they're responsive. And for some children, you may need a little bit more of an annoying stimulus. So sometimes tickling their nose, pinching their shoulders or something to see if they're responding to you. And if they respond to you or push you away, that's less likely to be a seizure. So when we're thinking about seizures, it's really important to know how to document a seizure. So we think about 3 parts of a seizure: what happens before, what happens during, and what happens after. So it's important to talk about the date and the time, marking that down, and also the length. If you're able to, try to time the seizure. Document what happens before the seizure. Were there any triggers, any changes in behavior? What was your child doing beforehand? And then describe the seizure as best you can. Describe the body parts involved, any kind of movements, their level of awareness, and anything else that you might notice that would be helpful. And then document what their behavior was after the seizure. Many children will act very confused and often very tired for several hours, especially after the generalized tonic-clonic seizures. Of course, we would want to know if an emergency seizure medication such as Valtoco or Nasalium or Diastat was administered, or if you needed to call 911. I want to show you some examples on how, some templates that people have provided that allow for some seizure documentation. It helps to keep information organized. So a few of these places, this is an epilepsy foundation who has developed an example seizure diary template. And so as you can see, this is the stuff that I had mentioned that is important to document. The Epilepsy Foundation also has a more detailed seizure diary. It really all depends on your preference on how you would like to document your child's seizure. But either one of them are just fine. It just helps to organize your thoughts. And the Epilepsy Foundation also has a seizure calendar, so you can mark, seizure activity per day, also kind of thinking about overall seizure frequency. So this is really helpful when we're thinking about seizure trends. And finally, there is an app called Seizure Tracker, which is a way to electronically record seizures. This can be helpful if you want to be able to graph the seizures. You can print out reports, look for trends, and these reports can be shareable with your clinician. And I'd like to thank you all for attending this talk. It's been an honor. Thank you very much.
I'm Audrey Thurm, a psychologist who's been involved in this PCORI series of grants for the last 4 years. And I'm here with Beth Potter, who I think is going to say hi. She's at University of Ottawa, and we've been partnering together with this group to work on this. We're going to take a step back now because that was a lot and a little bit intense, and maybe everybody wants to take a breath after seeing all that. But actually, for a moment while we transition over, you can jot down right now on page 8, which is about seizures, if you want to take any notes about what you just heard and how that may relate to what's ever happened in your child's life or not. And the point of all this, it was not to, show videos of things that are difficult to watch, but really because all of this is about educating all of us about what will be the best ways to document for trials. As you can imagine, trials might have seizures, and this is what the group has decided early on. Seizures are a super important outcome. How do we figure out how to do that? So we just thought educating and making sure that everyone's aware these materials are available, so that maybe not today, but going back and trying to think about seizures for your child, that this is all available for you. So now I think Beth is going to talk and take a step back to just go over where we've been with this project and where we are now, and then we're going to focus on the neurodevelopmental outcomes. We've been the GAA plasma and the MRS, which we're going to talk about later, and the seizures are a little bit different, but now we're going to focus on some of the developmental outcomes. So, Beth, are you there? Great.
Yes. Can you hear me?
Perfect.
Great. Thanks so much. I'm delighted to be joining this group virtually. I really wish that I could be there in person for the whole conference, but especially for this afternoon. And I'm really enjoying learning along with everyone else online here. And so Audrey and I want to just walk you through, and I'm going to walk you through in particular, the first of these 2 grants that were funded by the Patient-Centered Outcomes Research Institute and connected to the Parents Advancing Research Network's a set of projects that Heidi already mentioned. So these were grants that were initiated by ACD. They were engagement awards, and it's an opportunity that aims to build capacity and skills of parents, families, and caregivers, and individuals within the broader healthcare community. So it's really been about learning and engaging together. So go to the next slide.
Oops. Hold on.
So this was the first project in this set of 2 projects, Parents Advancing Research Networks. This first project, led by Heidi Wallis and by Dr. Sylvia Stockler, focused on developing a core outcome set. And so I'm not going to spend any more time on this slide because this is kind of a summary of the next few slides. So we'll go to the next slide. So as all of you know, for many rare diseases, there's limited evidence available to guide care, and evidence can be quite difficult to generate for rare diseases because of the small number of patients around the world. And so to make best use of our limited resources, we really need to focus on research that includes high quality study designs, and that especially includes clinical trials where researchers measure outcomes to determine if treatments are working. And that research needs to address the questions, concepts, and measurements that matter to the patients and caregivers and healthcare providers who make treatment decisions and who stand to benefit from the evidence that we're generating. And in recognition of the importance of the patient voice, the FDA has issued patient-focused drug development guidance series specific to enhancing the incorporation of the patient's voice in medical product development and regulatory decision-making. Next slide. And so taking a step back, what is an outcome? Well, simply it's an observable or measurable symptom or sign of a disease. For example, how someone feels, what they can do, or the results of lab tests. Importantly, an outcome is something that is important to a patient or to their caregivers, and that they would like to see change in response to a treatment. And so outcomes matter. The outcomes that are selected to be measured during a study can determine the evidence that's considered when decisions are making about treatments and about making treatments available. And so it's critically important that researchers and our whole community are thoughtful in selecting the outcomes that we measure. Next slide. So why is this an issue? Well, if we're not thoughtful about outcome selection, the outcomes that researchers select might not align with patient and caregiver priorities. The collection and analysis of many outcomes is costly, so this includes both the financial costs, but it also includes people's time and the time that patients and caregivers spend contributing to research, including as participants. And if we're not thoughtful about the outcomes that we select, then different researchers measure different outcomes and the evidence can't be combined, making it harder to make treatment decisions. So go to the next slide and just expand on this last point. So if each research team, as shown here, decides kind of in isolation which outcomes to measure in their study, and they all measure different outcomes, then we won't be able to compare and combine the overall evidence and develop a body of evidence to help inform policy and practice. Next slide. So core outcome sets have been developed in order to try to address this challenge. So a core outcome set is an agreed upon set of typically 8 to 10 outcomes that are recommended to be measured and reported for all studies, including clinical trials, for a particular disease like CTD and GAMP deficiency. A COS represents the minimum set of outcomes to measure. Researchers for any one study might choose additional outcomes to measure in addition to the core outcome set, those that are particularly important to the question that they're trying to answer. But if they are all also measuring the core outcomes, that can help us to combine different studies to generate a body of evidence and ensure that the evidence that we generate reflects the priorities of patients, caregivers, and professionals. Next slide. So the core outcome set that we developed for CTD and GAMP deficiency was based on the recommended methods of the Core Outcome Measures in Effectiveness Trials, or COMET initiative. This is a worldwide initiative. It's led from the United Kingdom. It's not specific to rare disease, so this is across many different disease areas. And the COMET methodology recommends that we first review what's been measured in past studies and try to generate a long list of potential outcomes that might be important for including in the COS, and then gather input from experts and work toward a consensus on which outcomes are most important. And those experts need to include people who have lived and living experience, so patients and caregivers, healthcare professionals, and people who make decisions about care. Next slide. And so these are the 3 stages of our COS project. So in the first stage, we started with an evidence review to generate that long list of outcomes as a starting point. And we also conducted some focus groups with patients and caregivers to make sure that we didn't miss outcomes that hadn't been included in previous studies. And that led to the development of a list of 85 possible outcomes for including in the core outcome set. So that was quite a challenge because we need to remember to kind of narrow this down from 85 down to 8 to 10 of the most important outcomes. So at the next stage, we conducted a series of surveys called Delphi surveys, where families, healthcare providers, and researchers were asked to rate each of those 85 outcomes in terms of how important they were. And we asked people to participate multiple times in these surveys. And in the second and future versions of the survey, people were presented with the results from the previous round so that they could see that we were slowly coming toward a consensus. And based on those survey results, we were able to narrow the list down to 20 outcomes. And then we held a consensus workshop in November of 2023. And I think it's possible that some of you were there, but this really brought together some families, healthcare providers, and researchers to discuss in detail those 20 outcomes. And we voted and continued to discuss, and we were able to come to a consensus. Go to the next slide. Oh, sorry. Yeah, thank you. And so I'm not going to go into, sorry, one slide back. Thank you. So we didn't want to go into a lot of detail about all of the methods of all of these different study components, but we did want to share with you the Delphi survey participation. And in particular, to note that we had 150 unique participants in our Delphi survey from all around the world, including, as you can see on the right-hand side there, many patients and especially caregivers from both the CTD and GAMT communities. Next slide. And so this is my last slide here. These are the 8 core outcomes in the final core outcome set and their definitions. And you can see a link there at the bottom to the publication that reports on this whole study. But the final outcomes were adaptive functioning, cognitive functioning, emotional dysregulation, expressive communication, fine motor functions, MRS brain creatine, seizures, convulsions, and for GAMT deficiency, serum or plasma guanidinoate acetate. And with that, I'm going to turn things back over to Audrey to talk about the next steps in the project.
Great. So now I have about 3 minutes to introduce you to all of these. So again, we talked about the seizures and the MRS and the GA before, and now we're talking about the neurodevelopmental outcomes. And I just want to give you an introduction because we're going to have a break, and then we're going to really try to dig in to have a lot of participation and thinking about our own kids and how they all fit in here. So I'm just going to point out that you already saw this slide. We're here. We're at the Alignment Jam. I'm just going to point out a few of the many, many things we've done along the way. There was an exploratory jam, which was on Zoom, and some of you participated. And I'm going to show you some of the key quotes and sort of findings we had from that, where parents really talked about how would they think about measuring some of these things. And I'm going to try to fit that in with how it relates to how we actually do measure them in some of the measures that are used in trials. We also did a lit review, and tomorrow, and there's a poster, I'm going to go into details of that. We had no lit review to do about trials of CTD and GAMT, so that was easy because there haven't been any. So we used trials of other intellectual disability conditions where there have been many, many in the last 5 years. It's sort of exploding. So I'm going to show you some results of what measures were used in those trials as the closest we have. And then you can see here that we've done trainings and a lot of involvement of parents who've been here. And then we've done this community survey, which we hope people are continuing to fill out, but that should relate to the things we're saying. So just again, what is adaptive functioning? It's kind of easy to define because it's just what we do. It's actually how we function. It's not what we might be able to do, skills that we have in theory. It's what we actually do in real life. And this goes all the way throughout the lifespan, to babies crying, to going on the toilet, to getting a job, to living independently. And we just divide it in our measures into these 4 domains or so: communication, daily living skills, which is personal, ability and how we sort of carry out life skills; socialization, being in the world, interacting; motor skills is another one. And so that's one way of defining it. And another way is conceptual, social, and practical. But our measures really ask us questions about how we do these things. And this is super important because it is what we mean by independence in life. But it's also important because it's how we define intellectual disability, which is a condition that a lot of kids with CTD are diagnosed with. And so we want to make sure that it's clear that what we're talking about goes into that diagnosis. Adaptive functioning is a key component of it, as is intellectual functioning or cognition. So it's not sort of a surprise that 2 out of the 7 outcomes are adaptive functioning and cognition. And so ways that we measure adaptive functioning, the FDA may say it would be great to have an observable measure, where we videotape your whole life and actually see it. That hasn't come to fruition yet. So the only way we do it really is through you all as caregivers. That's how we get it, is we do interviews or we do surveys where we get the information about what's actually happening, what a child can do on their own, what they can do with help or sometimes, or what they are not yet able to do. And so these are some measures that you some of you are very familiar with that are used. We are totally open to other ways, but these do range from birth all the way through the lifespan. The question is, do they have enough granularity to get at what would be a meaningful change in a trial? And that's one of the things that we need to really talk about more. But I just wanted to put up some examples. These are things. Can they buckle their car seat? Can they take their temperature? Can they take pills? Can they wash their hair? Can they go to the bathroom on their own? There are very practical questions about real life behaviors. So that's how it's measured. And then on the right here, as you can see from trials, the Vineland is a very, very popular measure, and it's even being used as a primary outcome in some trials. So it's very, very popular. And parents did talk about exactly these things, and toileting is a big one. Toileting, hygiene, dressing as things that they want to see. And so this aligns really well because our measure actually gives us these things. Then cognition is a lot harder. There are some measures, but for the most part, the regulators want this to come from the child themselves. And we all know that this is not so easy in a room, a strange new place, even in your school, to perform all these things to the best of their ability. In a situation where it's contrived is not easy. But these are some of the measures that have been used. Not so much in CTD, although we're trying to. And then this is what we need to do is think about which measure and how we can make sure we have the granularity from them, and that we are doing the things we can to make sure we're maximizing. And so these are some of the things that parents said in the JAM. They would love it to be just based on IEP progress and that I don't think it's going to work because IEPs are so different and we don't have standardizations of them, but we can think about how to include that. But really important skills are just remembering, learning, and then following instructions, and then a lot of concern about, attention, focus, especially from danger. Those are some hard things. You're not going to put a child in the street in our clinic, but to measure. But we need to rely on parents for that and think about how we can really best capture ability to learn, other than some of the vocabulary and puzzles that we already use. Expressive communication is another huge one, and I know a lot of people are familiar with. So some of our measures, like the Vineland of adaptive functioning, include communication in them. So that's good because we can do lots of things with one measure. And the Bailey also has communication. And so these are some of the things that parents said, that they really want to make sure that kids can express their emotions when they're hurt, how they feel, be able to advocate for themselves. And so these are some of the things that we do get on these adaptive functioning measures. I'm going to skip really fast here because I want to make sure you have your break. And again, this Vineland where you get from parents. And then fine motor is another one where, again, we get some of this captured on our existing measures. We can really measure it by having a child play with blocks, scribble, do all these things in a testing environment. And parents definitely prioritized fine motor tasks in terms of how they affect daily living, eating, drinking, being able to dress and do things like that. And then a really hard one is what we're terming emotion dysregulation, but it's really about reining in maladaptive behaviors, aggression, and being able to regulate themselves, not have tantrums. And so there are some measures for this. This is a little bit, I think probably needs a little bit more work. But there are measures where irritability is captured that are all parent report so far. And again, some things parents said were that they wanted to have fewer or less misbehaviors, certainly reduction in aggression, and then relating to attention. And a lot of this relates to communication. You can see how these are very interactive with each other. And so I'm going to stop here, and we're going to have just a few minutes break. We are so really, really lucky. There's been probably over 40 parents who have been involved in these efforts so far, but we're trying to gear this towards new parents. I know there's a lot of people who are very familiar with the research and what we've done. And so we were really lucky to meet a new parent who is a parent and also a neuropsychologist, so understands maybe too much of what we're saying from both ends, who is on the younger side, or their child is. So I'm going to introduce Jill Henley to come up and give her story a little bit to start to get the conversation going that we hope to have in this half.
Thank you. Okay, hold on. Can you hear me? No. Okay. Hi, everyone. I'm Jill Henley, and like many of you, I am a parent of a child with CTD. My son Lucas was diagnosed in December 2024, a few months after he turned 4. And as many of you know, that diagnosis rocked our world. It set off a flurry of appointments and specialists, research and advocacy. There were phone calls with Heidi and emails exchanged with other CTD families to help shed some light on what this new path meant for Lucas, our older daughter Drew, and for my husband Matt and me. After all these months, it's hard to express how grateful I feel to be here in person with so many people in this room that care so deeply. Like Audrey said, the paradoxical part of my story is that when I'm not moonlighting as a parent of a child with a rare disease, I'm a pediatric neuropsychologist. During the week, I'm the person on the other side of the table. I listen to parent stories, the signs and symptoms that brought them to my office, I evaluate children and adolescents, and sometimes I am the person delivering the hard news to families that will rock their world. My life as both a parent and a clinician can be a bit surreal. Yet, this is exactly why I'm standing here in front of you today. I want you to think of me as the liaison between the clinical side and the family side. As we all know, ACD is racing towards a cure for creatine disorders. The directors and board members spend so much time that's him. Evaluating proposals, educating the public, and talking to researchers and drug developers to see what is possible. I know that families pitch in by organizing events, conducting outreach, and raising money. And we know from the newsletters and social media posts that all of this work has been meaningful. There's a lot of potential out there for a cure, but they are only going to know a cure works if they hear it from us. Getting creatine to cross that stubborn blood-brain barrier only matters if it makes a difference in the lives of our children and our families. And that is why we need data. Specifically, we need data in the form of rating questionnaires. As a clinician, I love rating questionnaires. Parent responses allow me to see what really matters to the family and where I need to focus my intervention. Yet as a parent, I also know how hard that is to fill it out. It was hard for me to do it for Lucas's neuropsych evaluation on the measures that I use every day. The surveys I've had to fill out for ACD have at times felt paralyzing. I would look at the question and think, I'm not sure. I don't know if what I'm seeing is real. Am I overstating this? I don't want to get it wrong. When Lucas has difficulty with something, my husband and I will undoubtedly look at each other and be like, is this a capability problem related to the diagnosis or him just being a stubborn 5-year-old boy? Sometimes we just don't know. And the other thing that is hard for me, at least, is that the mark is always changing. I remember when all I cared about was Lucas's ability to walk, so we could be in public without him crawling all over the floor. Yet when he finally figured it out, something that was so important suddenly became not an issue. These past few weeks, our focus has been potty training, and literally nothing else matters to me right now than pee-pee in the potty. So if you take one thing from me today, let it be this. You cannot give a wrong answer. You can only give an honest one. And when you answer a question and you're unsure, that uncertainty is okay. It's not a failure. It's information. And the measures are built to hold all that information. You don't need to be a researcher. You don't need to be a clinician. You need to be the expert on your child. And what I've learned from working with parents is that nobody on the planet knows their child better than them. And what I've learned during doing some of my clinical work with ACD is that when a treatment is being studied, researchers and drug developers need a quantitative way to see whether our children are changing. It's not just, do they seem better, but they need something measurable. Outcome measures are how we turn, I think something shifted, into evidence that a treatment is effective. And without that information, drugs that could genuinely help our kids might struggle to make it to market. I do not say that to discourage you. I say that because I know what you have all been through to get here today. There was a gut feeling. There was noticing the small things that then became big things, that something wasn't right. You made appointments with neurologists and geneticists. You fought with insurance companies and underwent testing with needles, with sedation, with electrodes, while absorbing a diagnosis that dramatically changed your life as you knew it. And yet, you rose above it. We're all here. Deep in the night, in the depths of the internet, you became budding experts in small molecules and the role of creatine in brain function and development. You navigated IEP processes and OT and PT and speech. You figured out which pharmacies produce glycine and arginine and how to get it to your doorstep. You weighed and measured gram after gram, day after day, and some of you made the hard decision to stop the supplements when the cost became not enough benefit. The cost did not outweigh the benefit. And that is an extraordinary amount of work. I don't say that to flatter you. I say it because the thing that we're about to ask of you, to engage with these measures, to answer these questions you might feel unsure about, is nothing next to what you've already done. You've done the hard part. Always, sometimes never, 0, 1, 2, 3, even a short response, that's peanuts. So now I'm going to turn it back over to Audrey to talk more about trials and outcomes. But if you have any questions, please come find me. I'm always here to help.
After that, I'm going to take another step back because we realize that all of this is to trials that may be coming very soon. There are trials happening, which I'm going to show, but you need to know a little bit more about what trials are to really put this in context. So I'm on the next slide myself. That's what I'm going to do. So this is the video that I'm going to try to show right now. Let's see.
Trials are research studies that involve people. Most clinical trials to test new cancer treatments are done in a series of steps.
Forget the cancer word. Forget the cancer word.
If a new treatment is successful in one phase, it moves to the next phase. Let's take a look at the 3 main phases of clinical trials. Phase 1 trials are small, enrolling less than 30 patients. Phase 1 trials are designed to find a safe dose of the new treatment, determine how the treatment should be given, and learn how it affects the body. If a safe dose is found, the new treatment goes to phase 2 testing. More patients are enrolled, usually 100 or less. Phase 2 trials study how the treatment affects the body and how the treatment works for a certain type of cancer. If a new treatment is found to be safe and to have some benefit, it goes to phase 3. This is when many participants are needed, usually more than 100 and sometimes thousands. Phase 3 trials compare the new treatment with the current treatment to see which one is better. One thing is certain with any phase trial. By taking part, you will help future patients by helping today's scientists learn more about cancer.
Can we cut the video now? Thanks.
For more information about...
Great. Back to the slides. So yeah, the reason why I said cancer is because only the National Cancer Institute has enough money to make beautiful videos like that. But I wanted to show that because there are thousands and thousands of patients to do those kinds of trials for those conditions. We don't have that, right? We have who's in this room and some more. But it is important to know there's not just one kind of trial, there are many phases. And the first phase really is only about safety. And those are really difficult trials because we don't know if it's going to work. Then we get to phase 2, 3, and 4, where we can be looking at efficacy. And that are these outcome measures. That is the efficacy. It's the seizures. It's the daily living skills. That's what we're talking about here is we have to pick one as the primary, but all of them can be outcomes for efficacy. That's what we're getting to. But again, what I say here is in rare diseases, all these sample sizes are going to be much, much smaller. Every trial, every child in them is so precious, but we still have to go through these processes because this is all the FDA knows. So for the creatine deficiencies, we have some trials that you'll be hearing more about in this meeting that are happening, some that may be happening soon. And I'm going to talk a little bit more because I know there's a lot of buzz about gene therapy. As well as small molecules. But there are other kinds of trials, like behavior therapy trials, that don't go to the FDA, that don't have to follow those rules exactly. We are not going to memorize this right now. We're just going to make sure we understand that when we're talking about gene therapy, there are many types. And this is important because when we're talking about low risk and high risk, there's many granularities here within it in terms of whether you need to be sedated. For ASOs are ongoing, where you have to get the treatment maybe every few months, which might require a procedure to get that treatment every few months, where some of the other types are one and done, that's it. But they may be a little bit more invasive in terms of having to be in the hospital and maybe get some other drugs to work on your immune system before you get them. But again, this is where we are today with these trials, but they're going to be changing. But the important point to know is that there are many different kinds and they're continuing to evolve. So now I want to talk about how we term risk, because everything we're talking about is a high risk or a low risk, but that's always weighed to potential benefit, right? That's what we want, is benefit from these trials. So how does sort of the IRBs, REBs, and the FDA think about risk? They would love studies to be not involving any more than greater than minimal risk. And minimal risk means what happens in everyday life, on the playground, walking upstairs, that there's risk in life, right? And so that's what they mean by minimal risk. But very few of these trials that I just mentioned are going to have minimal risk. They're going to have greater than minimal risk, but when they do have greater than minimal risk, they want that to also include the prospect of direct benefit. The benefit is what we're talking about. It's the efficacy, is the getting better in daily living, communication, all these things. Then there's another potential avenue of greater than minimal risk with no prospect of benefit, but that has to definitely have generalizability of findings that would help us. So the prospect of benefit may differ depending on the phase of a trial. And that's what I'm trying to get at, is these earlier phases, which may be open label, where everybody knows what's going on, those may not necessarily have efficacy or as much prospective benefit, because we're still learning what the drug does to the body. Then phase 2, 3, and 4 may certainly have more benefits because we've already gone through phase 1. We know what it does to the body. And now we're working on either dosage or just trying to see efficacy and who it affects based on who's in the sample. So I'm not going to get into the details of this, just to say that the influence of the assessment of the prospect of this benefit depends on a lot of different things. What happened in the animal model, what's happened with adults or other kinds of patients who's had this kind of drug. So it's just very, very complicated how we decide what the benefit is. And then how do we define what is a risk, right? When we're saying this high risk or low risk. As I said, the minimal risk is what happens as we're walking down the street in life. But the greater than minimal risk is something that exceeds the boundaries of our normal life. But it could be from a blood draw where you might get a little bruise, but it could be from being in a hospital and getting sedation and potentially having effects of that. There are huge variability in what it might be that causes this greater than minimal risk. And I just want to point out that the risk, certainly we think about physical risk, about bruises or getting hurt or being injured for life. But there's other risks too, right? Psychological, how much stress it's putting all of us under if we're going to have this. And there's economic and social risks too that we have to think about. And so all this leads to what we're talking about, low risk and high risk, is that we keep on talking about smallest meaningful difference. And that's because the smallest meaningful difference is what's coming from the caregivers or the patients that is enough for us to say this works, right? We can say that one group it does better than another, but we actually might not have that if the study doesn't have a placebo or is not randomized. If it's everybody's getting the drug, we just need to know how much is better. How much is it? Everybody toilet trained? Is it everybody being able to read or write? Is it what is it? And we think, and research is showing, and this is from another condition of SCN2A, that probably those things are going to differ based on the amount of risk and how long the trial is and how intense it is and what it is, a one-shot gene therapy versus something you get every month. And then it's probably going to also differ based on ability level. And so for SCN2A, it was whether the kids could walk or not made a difference in what parents said was that smallest meaningful difference.
Hey guys, my name is Celeste Graham. I'm mom to, wrong one. There we go. I'm mom to Levi, who is 14 years old and he has CTD. We're going to take a quick high-level overview of some data gathered on the smallest meaningful differences that parents who participated in this project would want to see in order to make a low or a high-risk treatment worthwhile. The information I am sharing will be on a poster that we have with de-identified quotes from parents in the 2.0 cohort. So be sure to stop by tomorrow night to see those specific quotes. In each domain, there were very different examples mentioned as to what the smallest meaningful difference would be. So some examples mentioned included very small, minute details, while others included very broad things. Some examples mentioned were very early on skills. Others mentioned were very advanced. So just to give you kind of a framework of where this fits into everything, we've talked a little bit about the Research Jam focus group with the 2.0 cohort. We've talked about the literature review. Subject matter experts have given short presentations. So now I'm going to share a little bit about what information was gathered from the actual parents in their interviews. All right, I added some animation to hopefully help. So this project consisted of 4 mentors who all participated in PCORI 1.0, the Parents 1.0 project, the first 2 years. And then there were 19 new cohort participants. Out of that, there were 12 CTD families, 9 having male and 3 having females. And then there were 7 GAMP families, 3 males and 4 females. So just a quick note, while we've tried to consolidate this information into a few slides, it's representative of a snapshot in time, meaning that what is the smallest meaningful difference right now for someone may change over time. I know it has for us. Also, we found a lot of variability, as we all know, in what was meaningful to parents, and it often differs based on diagnosis, their age, whether they're male or female, things like that. So in general, in regards to a low-risk treatment like a small molecule, parents noted any small improvement in each domain would be a meaningful difference. In regards to a high-risk treatment, parents were cautious, but some parents would consider a high-risk treatment, such as gene therapy, if it were proven safe and effective. So these next 2 slides, like I said, are going to show some of those examples of the smallest meaningful differences mentioned by parents in this cohort, and there's a wide range. So first is adaptive functioning. All of the slides have similar formatting, so there's the low-risk treatment and then a high-risk treatment with examples following. So safety awareness was one, both at home and in the community, ranging from safety around walking up and down stairs, to being around hot things, to then being in the community, stranger danger, roads, things like that. Being able to accomplish self-care tasks in part or in whole, So feeding, toileting, bathing, brushing teeth, dressing, things like that. And then just an increase in overall independence. And this was very wide. This range was very wide, from just independent tasks to household and daily routines to then being able to care for themselves as an adult, kind of preparing for adulthood. In addition to all of these, some additional improvements that parents would, or additional smallest meaningful differences that parents would like to see if they, for a high-risk treatment, would be toileting. So being able to toilet independently, and then just an overall big increase in their skills. For cognitive functioning, academic improvement was one, and it ranged from just starting to learn again, starting to gain those skills. And then a very specific one was improvement in reading and math by grade level. Then following directions. So I kind of put this under executive functioning skills, but the ability to concentrate, so the improved attention span and focus, to then listening and following directions without additional prompting. And then somebody actually did state executive functioning skills. And there's the improved attention and focus. And then examples of additional improvements, being closer to their chronological age was one that I thought was quite interesting. Consistency, so consistently meeting their goals, their IEP goals, their IFSP goals, and then having more consistent testing. And then the last one is just overall being successful in life, whatever that looks like. For emotional dysregulation, a decrease in behaviors that looks like shorter frequency, so how often it happens, shorter duration, how long the tantrums are, and shorter intensity, so how intense they are. The ability to participate in events, whether at school or in the community, was huge. And then the ability to manage their emotions, or an increase in patience. So when they don't get to do a preferred task, or don't get to do what they want right away or at all. And then for high risk, better or consistent emotional regulation. So more ability to pause and understand limits, handle frustration, and then just a big increase in overall functioning in public. Expressive communication, consistent AAC, which is a communication device, so consistent usage across all settings to communicate. And then just being able to verbally speak in words or phrases, and then to communicate their needs and wants. And with the needs and wants, like to communicate how they're feeling, or if they're sick, what hurts. And then speaking in sentences. And then for the high-risk treatment, a big increase in overall growth, but then also nuanced conversation, which is this conversation like you and I would have. So they would ideally like to see that. For fine motor function, for low risk, like writing letters, numbers, being able to button or zip, and just progress in those daily skills, daily living tasks. And then for high risk, being able to actually communicate through written language, and then better hand control and coordination, which would aid all activities of daily living. And then for seizures and convulsions, confidence that seizures are under control, and then having a normalized EEG for low risk was mentioned. And then for high risk, stopping seizures for good, being seizure free. So on this slide, these are all of the outcomes from our core outcome set from the first PCORI grant. Many parents in this 2.0 cohort noted their most important outcome or outcomes, whether it was through their interview or through the notes on the presentations that they did. And this is the outcome that they feel, or outcomes that they feel are the most important to their kiddo or family to observe change in, even the smallest change. I do want to note that not every parent mentioned a most important outcome, and some parents mentioned more than one. So just as you look at this, but it looks like emotional dysregulation and expressive communication have the most, or seem to be the most important. but that's just representative of this group of parents and those who did mention that. And last but not least, so over the next 2 days, we've already heard from Jill, but you will get to hear spotlight talks from some of the parents that participated in the 2.0 cohort. Just to give you guys glimpses for you researchers in pharma and academia, glimpses of the vast variability among each individual with a creatine deficiency, and what we as parents and caregivers want you guys as researchers, providers, and pharma to know is important as we press on towards finding a treatment or cure for creatine deficiencies. Emily.
Hello again. So I'm Emily. I'm a staff member with ACD. I serve as the patient registry coordinator. You've probably heard, if you're a parent, you've probably heard me bug you like, hey, complete your surveys on the registry. And I will definitely be doing that this weekend, so be prepared. But I want to give you a little glimpse into a survey that we developed as part of this project. It's the Parents 2.0 Community Survey. Just to highlight, again, we've talked about the various steps in this project. I won't go over it again, but this is where we're at, community survey. We're still collecting results. So if you haven't completed the survey, you still can. So the goals, we had a couple goals for this community survey. One, to collect information from CCDS caregivers about their perspectives on outcomes and outcome measurement tools. And we also wanted to learn from these caregivers what smallest meaningful changes they would need to see in order to know that a treatment was in fact working. So very briefly, we developed this survey in partnership with our Parents 2.0 cohort, as well as several of our subject matter experts who are here with us today. We created an educational video as part of this survey about meaningful changes, and I think we will be sharing that. You'll be watching that tomorrow. It's a really great and informational video. This survey, we only asked about neurodevelopmental outcomes and seizures because these are the outcomes that we really need input from caregivers on. And this survey was launched within ACD's Creatine Info Patient Registry. For those of you who are maybe new or unfamiliar with our registry, this is a patient and caregiver reported registry. It's a platform that ACD, we work through the NORD platform. This is ACD's registry, and it's a great resource to collect data from patients and caregivers. So, who participated? We had 54 total participants. You can see the breakdown of CTD and GAMT there. Unsurprisingly, the majority of responses were from CTD participants or families. That makes sense. It's more common than GAMT participants. With unsurprisingly more males responding than females, though we did have five CTD females participate. And then for GAMT, we had a pretty even split between males and females. You can see the age breakdown there in the pie chart. The average age was 12 years with a median of 10. We definitely tend to have younger participants in this survey, and this, I would say, is reflective of our registry as a whole. So we asked lots of questions, but I'm just going to highlight a couple of things today. One of those questions was to rank the importance of the following outcomes in terms of what you would want to see improve in an ideal treatment for CCDS. So they could choose between the 5 neurodevelopmental outcomes and seizures and convulsions. And again, as a reminder, this only includes the neurodevelopmental and seizure outcomes. So I'm going to break this out by diagnosis, and for CTD, we're going to split it out by males and females. So for males with CTD, there were 36 participants who completed this survey, their top outcomes were adaptive functioning or daily living, cognitive functioning, and expressive communication. And if we really zero in on what was the outcome that families said, this is my number one outcome, this is the breakdown. And over 50% of participants or families are saying cognitive functioning is my number one outcome. This is what is important to me. And then it's pretty evenly split between emotional dysregulation, expressive communication, seizures, and adaptive functioning. When we look at CTD females, this is, again, proceed with caution here because we only had 5 participants. But their top outcomes were cognitive functioning and emotional dysregulation. If we look at the outcome that they are saying, this is the most important outcome for me, this is the breakdown. And it's a little bit more scattered. Again, there's only 5 participants. So this is a call out. If you are a family of a daughter with CTD or you yourself have CTD, we would love to hear from you. We need more females with CTD to participate. When we look at GAMP participants, we had 13 participants. We pooled the sexes together. Their top outcomes: adaptive functioning, cognitive functioning, and expressive communication. I hope you're seeing a trend here. Again, when we zero in on what was that top ranked outcome, it's pretty split. Cognitive functioning, seizures, and expressive communication are each about 25% of responses, and emotional dysregulation and adaptive functioning. From here, I wanted to look at seizures. Where does seizures fit into this? And unsurprisingly, seizures are important to those who have them. So 43% of participants who have had at least one seizure place seizures and convulsions in their top 3 outcomes, compared to the 12% of participants who have never had a seizure. So this is not surprising, but this just is confirmation for us. So moving on, transitioning to what are meaningful changes, smallest meaningful changes. You're going to hear that a lot over the course of the next few days. This is the change in skills or behaviors that a patient or their caregiver would need to see in order to say, yes, that a treatment is working. So we asked caregivers, what would be the smallest improvement in each of your top 3 outcomes that would be important to you or the participant in terms of the participant's well-being, function, or quality of life? Now, this was an open text response, so participants could write anything that they wanted. We then coded those responses based upon and we coded like what outcome are they actually describing. Sometimes in their response, they actually brought up multiple outcomes, so we recorded that. And we also tried to boil responses down into some basic concepts. So to give you some examples of what this looks like, I've provided some quotes here for each of the 5 neurodevelopmental outcomes. So the ability to cook a very simple meal independently, that came from a parent of a daughter with GAMP. Improving basic math like money, multiplication, problem solving, and reading skills. That's a cognitive functioning response from a parent of a daughter with CTD. For emotional dysregulation, that they could do homework without sitting and crying. That came from a parent of a 14-year-old son with CTD. Expressive communication, being able to tell us what's wrong when he's sad, hurt, not feeling well. That came from a parent of a son with CTD. And then finally, fine motor functioning, correctly handling a spoon or scissors, fastening buttons, or using a pencil with precision. And that came from a parent of a 7-year-old son with CTD. So this gives you just a little example of what sorts of responses we were getting from families. So from there, we took all of that and we built out what I think is a pretty cool word cloud. So I will try to walk this through. So this is kind of the basic concepts that we coded things into. So the larger the words or the responses, the more participants who indicated that was a concept that was important to them. And then the colors reflect the outcomes. So you can see at the top is the code there. Blue is adaptive functioning, red is expressive communication, green is cognitive functioning, purple emotional dysregulation, and black is fine motor. So the items, those 5 outcomes on the left, top left, are the outcomes from our core outcome set. But like I said, when we coded these responses, sometimes additional outcomes came up. And some of those outcomes included receptive communication and gross motor. So even though they weren't in our core outcome set, these are still things that parents are saying this is important to us. I would say they are fewer, but they are still there. So kind of your take home, this could feel a little overwhelming. Big concepts that parents are saying, I want to see. The smallest meaningful change would be independent toileting, independent dressing, understanding, being able to communicate their needs. You also see a lot of red, a lot of blue. So we've got adaptive functioning, expressive communication. But you also see there's a lot of variety. There's a lot of variability. There's not one single thing that everybody is saying, this is the thing that we want changed. It's going to vary depending upon situations, families, lots of different things. So with that, I will wrap up here. Oops, I went the wrong way. Okay, so like I said, there's no alignment on a single primary outcome. So looking to the future, this suggests that the primary outcome in a future clinical trial should maybe actually be a severity score that is made up of a combination of multiple outcomes. So we can capture lots of different things here. And that there's a range of smallest meaningful changes that patients and caregivers want to see. And so I, again, urge caution to our researchers and our clinicians in the room to really carefully consider the population that you're working with. We know that creatine deficiencies are a diverse population, so really thinking about those things when you're selecting an outcome measurement tool. And with that, I will turn things over. Thank you to everybody. Thank you for your time. Audrey, I'll pass that back to you. Thanks, everybody.
All right, last speakers.
Okay, so what I'm going to try to do is make sure I'm going to try not to be too repetitive with what we've talked about before, but maybe kind of bring things together a little bit. So figuring out how to align the tools that exist that might match the needs that we've been hearing about so far. That would be the win. So in our natural history study, we noted like what are some of the big milestones that our patients hit or don't, and these kind of fit with what we've heard so far, right? So most of the kids get walking, but not everyone gets words. Some people get seizures, and sentences are much rarer, and toileting is really down there. So I'm really getting excited about doing some toileting work. So toileting is a big life skill, and it's a problem for a lot of people with CTD. If you wanted to do something that had broad appeal, something like that might make sense. But this kind of figure helps you see, like, what is the population of CTD? What are we kind of big picture struggling with? So as you all, I think, know, a clinical trial is going to succeed based on the primary outcome measure. And the trick is you have to pick it sometimes not actually knowing if your primary outcome measure is your best outcome measure. But that's how things work. So that's why there's so much value in preparing, and I think also doing like a lot of pilot testing to figure out what could change, because a lot of things could change well in a trial, but if one of them doesn't happen to be your primary outcome measure, then the trial fails overall, even though there might have been some benefit. That's different than regular research. So in regular research, I can do a study and I can have 20 measures in there, and I can learn something from any of those measures and have a great finding and a great study and a great paper. But for a clinical trial, if I didn't beforehand say, this is my primary, this is the one I'm putting all my eggs in, this is the basket I'm putting all my eggs in, then the whole study fails. Okay. The trick with clinical trials, and this is a new area, developmental disorders and clinical trials is pretty new. There's not that many that we can learn from. And what we're dealing with, you've already heard that there's a lot of different levels in our patient population. An intervention is also going to interact with lots of other things. For example, the sequelae from the pre-treatment period. If you've got a newborn with CTD versus a 20-year-old with CTD, that 20-year-old has 20 years of experience, 20 years of development without an intervention. What can be overcome from that pre-treatment period is going to be really different than it might be in a newborn or a 2-year-old, and we don't really know. Developmental resilience. So when you are young, this is a concept that is there's an analogy in dementia and older adult. When you are older and you start to have a neurodegenerative disorder, you don't have development on your side. So if you're 70 and you start to have neurodegenerative processes, you have the brain of a 70-year-old, right? But if you are 2 and you start to have a neurodegenerative process, you have the brain of a 2-year-old, and that's still going to be developing. So you have some development on your side that can help kind of act as resilience. Does that make sense? Okay. And then co-occurring conditions. Not everyone has seizures. That's going to be a big factor. Not everyone has autism along with their CCDS. So those co-occurring things that are going to come in might interact with intervention or not, right? So seizures could be a good example. If the seizures, actually autism may be a better example. If you have autism and CTD, you might react differently to a treatment than if you just have CTD, right? Okay, so how do we measure all that? That's partly what we're trying to figure out. And will a different intervention have to have a different clinical trial design? For example, if you just take small molecule versus gene therapy, there's going to be a different trial design. A small molecule may be a medicine that you're taking over time, and you can see these small increments and you can change the dosage. A gene therapy, there's a whole bunch of different kinds, but it might be a one and done, and then you have to sort of wait for it to have an effect. Okay, and then what's the short term versus the long term? So we've talked about what's a meaningful change. That to me sounded like what is the smallest but most meaningful, or smallest change that would still be meaningful long term, right? But that's different than what is the first meaningful change? What's the first indication that there's going to be a meaningful change happen? And finding that first early sign of a meaningful change is what the goal is in a clinical trial, because if you can detect that first change, you know the long-term change is going to happen. Okay, we're not going to go through this, but just so you know, so when we did the natural history study, we tried a lot of measures. We tried three categories. We had performance measures. These are the ones we tried. We had parent questionnaires, and we had a variety of other things. And we learned different things from each of those measures. And we can go into that in more detail. But what we learned was what worked or didn't work in our population and in our study. Our kids were younger. We had sites across the country, and they may have been more impaired than if there was a different study. I think Dr. Curie is doing really good work in a different situation where she's got sometimes older kids, but also she's doing one site where she knows how to get these kids through this, and she has a lot more structure that is very similar, whereas for the natural history study, we were doing what would probably be more analogous to a national clinical trial where there's a lot of different sites. Okay. Just another thing to know about measures. So we've talked about rating scales and how important they are. Rating scales and measures in general, IQ tests, adaptive tests, are designed differently, and there's different scores that you can get from them. A standard score, statistically, is designed to stay flat. So it's really hard in a trial for our kids to get a change in their standard score. They have to not only do better than they would have on their own, but do better than every other kid in the entire population. That's a big ask. But, there are some kids, like There's some, people are getting testing after some treatment, and their standard scores are going up. So it's not like it's out of the woods, but it's a high bar. A raw score could be helpful, but I'm going to give you some examples of why a raw score is tricky. Raw scores are not linear, and I'll show you some examples of what that means. They can get more granular, but they're not linear, so it's tricky when you're trying to measure. And then a GSV, or a growth scale value, or a personability score, is another score that can be really helpful because it helps you see how are you doing relative to how you were doing. So it's better for this purpose than a standard score. We can go into more detail, but we maybe don't need to. Here's an example of raw scores and how they're not linear. So these are examples from the Vineland. This is the domain of personal daily living skills. That measure has 55 questions, so you can get a raw score from 0 to 110. And you score each item as either at 0, you're not doing this at all, a 1, you're kind of doing it, or 2, you're nailing it every time on your own. You can get age equivalents for a raw score, so that can be super helpful. What I did here was I just posted the age equivalents and what the associated raw scores are. So you can see there's 6-month intervals in the age equivalent, but there's not a uniform number of raw score items. Does that make sense? So some gaps have more items in them than others. And I posted some examples of just things to think about. So in this thing where it says difficulty level in between items is not equal, consecutive item examples. I took this from the Vineland. So at age 2, 3 questions in a row are very granular and very tied to the same incremental improvement in a skill. So can you use a tissue? Can you wash and dry your face? Can you wipe your face during a meal? Those are one right after another. Those are great. They're really tight. That seems very granular. You get to the age 4, now the items that are coming right next to each other have much more stuff in the middle. So can you cut food with a butter knife? Do you understand when you're 4 years old? Do you understand that exercise is healthy? Doesn't mean you have to be a fitness guru, but 4-year-olds can understand exercise is healthy. And can you wash your hair? Okay, so those are they are not as incremental as the 2-year-old examples. So that's just a little bit of into the weeds of how daily living skills, which are so critical to life and also really good for measurement, it's not as simple as just use this scale and we can make sense of it. Okay, I think we'll skip this part. This is just more on we could go into more detail, but I don't think we need to. Okay, what we haven't tried in our natural history study was a different kind of test called a criterion referenced measure. What we tried is norm reference, so comparing your child to every other kid that age. Criterion reference is different. Instead of comparing you to other kids your age, we're saying, do you have the skills that are needed for this particular thing? So for example, a norm reference question would say, are your toileting skills as good as they should be for your age? That's a norm reference. A criterion is, can you pee in the toilet, pull up your own pants, wash your hands? It gives you the skills and you're trying to meet the criterion. They're 2 different approaches. And we haven't done the second approach, but I'm thinking if we could make a criterion reference measure about toileting and getting dressed, maybe we could get somewhere, because those 2 things have a lot of skills. It's pretty objective. You could probably come up with 50 things that are involved in those and come up with a good measure. And then the other thing we haven't done, I think, enough of is to see what changes in comparison groups that might have intervention. So for example, there's these folks who have a subset of CTD who do respond to supplement. What changes? It seems like in some cases it's expressive language, which is exciting. In GAMT, before and after treatment, we know that some things will change. Is GAMT a great model for helping us understand what's the earliest sign that we might see in CTD or something else? Okay. Yay. Yeah. All right. I think we can stop there.